Hey everyone, and welcome. Today, we're diving deep into angina and myocardial infarction. We're going to build a really solid study guide to help you absolutely crush these concepts, not just for your exams, but for your real-world clinical practice too. Here's how we're going to break it down. We'll start with the fundamentals, then move into what you'll see in your patients, how to diagnose it, what to do about it, and finally, we'll tie it all together for the NCLEX. All right, let's get into it.
Okay, first things first. We have to lay the groundwork and really understand the crucial difference between angina and a full-blown heart attack.
So the most important thing to get about angina is that it's not the disease itself. It's a symptom. You can think of it like the heart's own alarm bell. It's screaming, hey, I'm not getting enough oxygen-rich blood down here. And that's usually because the arteries are getting narrow. That lack of blood flow, that poor perfusion, is what triggers that classic chest pain. And this slide right here, this is probably the most important concept to nail down. Ischemia is like the heart's desperate cry for help. It's a warning sign, and the keyword here is reversible. We can fix this. But infarction, that's what happens when that cry for help is ignored. That's permanent, irreversible death of the heart muscle. No coming back from that. Now, you absolutely have to know the difference between these types. Stable angina, it's predictable. Your patient mows the lawn, they get chest pain, they rest, it goes away. But unstable angina, that is a massive red flag. It's a key part of what we call acute coronary syndrome, or ACS. When that pain starts happening more often, gets worse, or shows up at rest, that's a sign that things are getting dangerous and a heart attack could be right around the corner. All right, so we've got the basics. Now let's talk about what this looks like in a real person. How do we spot a patient who's at risk, and what are the clues we should be looking for at the bedside? You're going to notice a theme here. A lot of these are lifestyle factors that can be changed. And that's huge, because it means patient education is one of the most powerful tools we have as nurses. We can genuinely change outcomes by talking to our patients about diet, exercise, and quitting smoking. I love this chart because it lays it all out so clearly. The two biggest clues to tell the difference between simple angina and an MI are right there: how long the pain lasts and if nitroglycerin helps. You know, if your patient's pain has been going on for more than 15, 20 minutes and that nitro isn't touching it, your MI alarm bell should be going off like crazy. Okay, so our patient's got chest pain. We suspect it's the heart, but how do we know for sure what's going on inside? Well, this is where our labs and diagnostic tests are absolutely essential. This timeline is pure NCLEX gold. Seriously, know this. It perfectly explains why we draw a series of cardiac enzymes over several hours. See, myoglobin shows up first, but it's not specific. Any damaged muscle can release it. Troponin, though, that's our gold standard. It only comes from the heart muscle, and look how long it stays elevated. It gives us this huge window to confirm that an MI actually happened. The ECG is like getting an instant snapshot of the heart's electrical system. So with ischemia, you might see the ST segment dip down. That's ST depression. But look at the one on the right. See how that ST segment is raised up almost like a little tombstone? That's an ST elevation MI, or a STEMI. And when you see that, it is a code red emergency. It means an artery is completely blocked, tissue is actively dying, and we have to move fast because time is muscle. Okay, the ECG confirms it. We've got an MI on our hands. So what do we do about it? Let's walk through the key medications that you absolutely positively have to know. You need to burn this mnemonic into your brain. MONA. It's your immediate action plan for an acute MI. Morphine for the pain, oxygen for the struggling heart muscle, nitroglycerin to open up those vessels, and aspirin to stop more clots from forming. MONA is your best friend in this emergency. So nitroglycerin is a super powerful vasodilator. It relaxes the blood vessels, which does two amazing things. It reduces preload, that's the amount of blood coming back to the heart, and it reduces afterload, the resistance the heart has to pump against. But because it opens up the vessels so much, your number one safety concern is a massive drop in blood pressure. That is why you must ask about medications for erectile dysfunction. It's a can't-miss question, because that combination can be deadly. Morphine is just fantastic for MI pain. Not only does it help with the agony, but it also helps calm the patient down and actually lowers the heart's workload. But with morphine, we are always worried about one thing: respiratory depression. You have to keep a close eye on your patient's breathing rate every single time. Beta blockers are a cornerstone of MI care. Why? Because they are proven to help people live longer after a heart attack. For you, the most critical nursing action is simple. Check that apical pulse for a full minute before you give the dose. If that pulse is less than 60, you hold the med, period. Then you call the provider. This isn't a suggestion, it's a hard and fast rule. All right, let's talk about the big guns, thrombolytics. We call them clot busters for a reason. They literally dissolve the clot that's causing the heart attack. They can be total lifesavers, but they come with a huge risk. These drugs aren't smart bombs. They don't just target the clot in the heart. They go after clots everywhere in the body. That means the risk for a major bleed is incredibly high. So getting a detailed patient history to screen for any contraindications is absolutely non-negotiable.
So if thrombolytics are about busting up a current life-threatening clot, these meds, antiplatelets and anticoagulants, are all about prevention. Their job is to keep platelets from getting sticky and to stop new clots from forming in the first place. For your patients, the biggest thing they need to know is about bleeding precautions. Oh, and here's a great little NCLEX tip for you. Ringing in the ears, or tinnitus, can be a sneaky sign of aspirin toxicity. Remember that.
Okay, we've covered a ton of information. Now for the most important part. Let's put all these pieces together and see how this applies to the kind of clinical judgment questions you're going to face, both on the NCLEX and out on the floor.
All right, let's break this down just like you would on the exam. We need the one thing that separates stable angina from an MI. Well, what's the hallmark of stable angina? It's predictable, right? And it goes away, so the answer has to be A. Relief with rest in nitroglycerin is the classic sign. The other options are all characteristics of an MI, not stable angina. After someone has a heart attack, your job is to be a hawk. You have to be constantly watching for these life-threatening complications. The heart is a damaged muscle, and it's incredibly vulnerable. For example, if you suddenly hear a brand new heart murmur, that could be a sign that a valve was damaged by the MI, and that's an emergency you have to report immediately. This right here is your playbook. This is your immediate action plan. Your patient says chest pain. What do? Step 1, stop everything and sit them down. Step 2, give the nitro. And what's step 3? Assess. We never just give a med and walk away. We act and then we assess. Act, then assess. If that first dose does nothing, that's your cue to escalate and get more help fast. And this is where it all comes together. This is clinical judgment. The pain's better, which is great, but look at that blood pressure. It's soft, and that's a known side effect. The protocol says you can give more, but should you? Do you risk dropping their pressure through the floor? Or do you hold off and risk the pain coming back? Your priority is always patient safety. In this case, you'd almost certainly hold the next dose, recheck that blood pressure very closely, and let the provider know what's going on. That decision, weighing the risks and benefits in real time, that's what it means to think like a nurse.